Everybody, this is Dr. Ed Park. Today we're going to be talking about shoulder treatments. We see these massive shoulders and we see a little bit about what that entails. And let's dive a little bit deeply into the shoulders. To recap, I went to Harvard undergrad and for my residency at the Beth Israel Hospital in OBGYN. I am a medical doctor with a master's in public health. In 2016, I was consulting for a company. Individual wanted to use exosomes for anti-aging. And then in 2018, I heard my colleague, Dr. Jordan, talk about his motorcycle accident. I thought if it's true, I should try it. So I tried it on my knee, my Achilles, and my rotator cuff, and indeed it did help. I also created an online provider training course, just 12 hours self-directed, and I can do on-site training in the 6 states in which I am licensed. I also wrote and narrated last year a book called Exosome Songs of Healing, and you can pick that up on Amazon. So exosomes, as you might know, are 100 nanometers. That means they're below Abbe's light limit. 200 to 215 nanometers is the limit at which light can be used to see things. Below that, you need electrons or electron microscopy. So cells are bigger. Cells are 10 microns. Big human ovum is 100 microns. So that's 100,000 nanometers. These are how cells communicate with each other. They're little spheres filled with proteins, mRNA, and blocking mRNA. And there are tens of thousands of studies to implicate them in aging and in disease, as well as wellness and healing. So if we look at the electron microscope, we see that these 10 or 20 little spheres were being extruded, and the scientists just kind of assumed that they were poop. Just as an alien looking at humans would say, oh, all they're good at is making poop. But as we see, Nikola Tesla, with hundreds of patents from free energy to wireless transmission, he certainly was expressing more than poop on that toilet. Uh, when you grow stem cells in these pentagonal flasks, they will, if they sense danger and the need, secrete exosomes. So you just need to filter the bath water, and in them, you will find these exosomes if you filter them with this thing above me, tangential flow filtration. So this is how we heal. Back in May, I went to Australia to listen to 1,000 of the most brilliant people. Well, not all 1,000 talked, but they're very humble about what they know. So the exosomes we generally use are the ones formed in these MVBs. That's the sort of electron micrograph you saw. But there are bigger ones too. There are microvesicles that are much bigger that can even share mitochondria. This is how cells communicate. We didn't realize this until about 17, 18 years ago. In the past, people used PRP, inflammation would ensue, then stem cells would come and secrete exosomes. Now we can just get exosomes and forget the first three. How do they work? They cause stem cell proliferation, dedifferentiation. They can grow extracellular matrix. They shift the immune system from Th1 to Th2, and the macrophages go from inflammatory to anti-inflammatory, M1 to M2. They also regrow blood vessels. So why mRNA? Well, a protein is a one-off, but an mRNA is the blueprint, or like the piano roll in a player piano. So one mRNA can be read simultaneously, as you see above on the electron micrograph. This one message is making many, many proteins at the same time, process which is illustrated in that cartoon in the middle. I've done about 2,700 procedures, very rare complications, 21 times, one knee infection, which can happen with any injection of steroids or hyaluronic acid, occasional shingles, that's twice. Again, complications are very rare and they're very anti-inflammatory, so there's no allergic reactions and there's no antigens to be rejected either. So shoulder is one of our more popular procedures, 161 injections. Here's a histogram showing the kind of things that people ask. The consent above is one that everyone has to read and sign. It says exosomes from these stem cells are anti-inflammatory and can cause stem cell regeneration, but there's no guarantee. It's not FDA approved. It's not standard of care. The slide I got from the conference shows there's about 142 exosome studies throughout the world, most of which are being done in the US. If you look at the Cochrane review for corticosteroid injections in the shoulder, which is the standard of care, even though it's not FDA approved, it says that the available evidence is kind of questionable. The effect may be short-lived and small. It may be no better than taking aspirin or Tylenol. Similarly, intra-articular steroid injection may have a slight benefit for adhesive capsulitis, which we'll talk about. Other than that, the evidence is shoddy and poor. So, what are the shoulders? Well, the blue is the axial skeleton consisting of the cranium, the ribs, the spine, and the sacrum coccyx. Below, we have the pelvic girdle, and above, we have the pectoral or shoulder girdle. So, the real key thing you need to understand is this amazing bone called the scapula or the shoulder blade. So, above me, you see the shoulder blade on the left facing us. That's the chest side. On the back side, there's this spine. Going back to the front side, there's a little bump or knob in the middle top. You see that? That's called the coracoid process. And we'll come back to that. If we catalog the muscles of the shoulders, we usually have problems with the deep muscles. These are the rotator cuff muscles that are sort of these inside positional muscles that keep that arm seated in the shoulder blade. The powerful superficial muscles that move the arm and torso in relation are the trapezius, the trapeze artists, the deltoid, like that Roman armor. And then we have the latissimus dorsi next to me, really big in swimmers, obviously pulling that water towards them. If the scapular muscles consisting of the rhomboid minor, the rhomboid major, and uh, levator scapulae, that's the one that attaches to the C spine, are out of whack, you can get this, what this gentleman is demonstrating, which is a winged scapula, or one that's not being held in place. Levator scapula shown above. In the front, again, I mentioned that little bump, that coracoid process, that little knob on the front. Three muscles connect to that. They are the pectoralis minor, the short head of the bicep, and the coracobrachialis, shown on the left. Of the four rotator cuff muscles, the one that's on the inside scalloped shell of the forward-facing scapula is the subscapularis. That's what was hurting me, and that's the only one that's involved with internal rotation of the arm. You can see here where the pec major attaches. Bicep brachii has two heads, and the coracobrachialis we see again on the left, which is a arm adductor, a deductor. Good to mention the bursae. Bursae, plural, are these gel bags that Mother Nature put in high friction areas between muscles and structures like bones. So the subacromial bursa is the gel pack, which sits in the subacromial region. So just like the knee has these gel packs, the shoulder has a bunch of these too. We'll get a little bit into these ligaments, but the main thing you should understand is the subacromial joint. So what is that? The acromion is the hook of the shoulder blade, and it touches the clavicle, which is the collarbone, forming the AC or acromioclavicular joint. So below the AC is the subacromial bursa, which is the area that cushions the supraspinatus muscle and, arguably a little bit of infraspinatus. So if we're treating a rotator cuff injury, we usually inject in the subacromial area. This is good for impingement. Gentleman above is showing impingement as he raises his arm. As you bring your elbow under your chin and raise, that will make that space smaller and cause pain. Impingement can be related to a bone spur in the acromion. So that little hook that joins the clavicle could have bone spurs and be just shaving down that rotator muscle that hurts. So a doctor would need to go in and shave that back up so it can pass with resistance. The AC joint is kind of like a joint, but it's really just tied together with ligaments. It's not like a joint that's meant to move. If it is moving, it's going to hurt when you pull this band across. This woman is demonstrating. If you have a separated shoulder, that joint is no longer intact, and that can hurt like the dickens. Of course, the clavicle can snap mid portion, but oftentimes the weakest part is where it joins the acromion. The glenohumeral joint is usually where we see the pathology in addition to the rotator cuff, although the AC can get separated or injured as well. The radiograph above me shows the hallmarks of this. You could see like a cam type growth or pouching of the bone, that is bone spur. You can see that the black area between the head of the humerus and the glenoid fossa is narrowed. That means the articular joint surfaces are narrowed. And if we had an MRI or a nicer view, we could see cysts in the bones. This is all osteoarthritis, part and parcel of getting old. It's worth it to look at the glenohumeral ligaments. Above me, you see some of the glenohumeral ligaments. The ligaments, along with the muscular attachments, which I guess technically are tendons, form this 360 capsule, right? So on the left, you see looking in with everything sheared off that the supraspinatus muscle is the superior part at 12 o'clock. Behind that, the external rotator, the infraspinatus is there. And then the teres minor at like 7 to 8 o'clock. In the inferior part, you have the anterior glenohumeral ligament and the anterior band in orange and green. And then at 3 o'clock, you see the medial glenohumeral ligament, and then the superior glenohumeral ligament, and the long head of the bicep actually attaches here at around 12:30, and that is the top part of this. When you dislocate your shoulder, you do an O'Brien's test, you can see what happened. On the left, in the blue is intact, on the red is injured. If you have an anterior dislocation of your humeral head or dislocated shoulder, you can get this trauma to the labrum, which is called a Bankart tear. If sometimes it dislocates posteriorly, that's a posterior labral tear. Very common injury is superior labral tear or SLAP, standing for superior labral anterior posterior. And then panlabral is 360. So if the lining, just as the knee has a meniscus, the hip and the shoulders, they refer to that lining as the labra. If it's teared, this is what we're talking about. And of course, dislocation, trauma, acute injury, but also arthritis makes those cartilaginous surfaces brittle, kind of like worn out leather. The O'Brien's test, the patient with their thumb pointing down, if you push down and they resist and it hurts, it's indicative of a labral tear, possibly in the top part, like a slap. And if they pronate and put their hand up and it doesn't hurt, then that is even more evidence of a slap lesion. Rarely you'll see a frozen shoulder, which is also known as adhesive capsulitis. It can be caused by unknown factors, diabetes, thyroid disorder, immobility, like when you have a brace after breast surgery. It's basically contributed to by inflammation and fibrosis. Again, the Cochrane says that if you put steroids in the glenohumeral joint, you might get a slight benefit, although generally this thing waxes and wanes. In other words, it freezes and thaws. It takes sometimes 6 months to 12 months to resolve. It hurts. And I'd love to try it to resolve it with exosomes one day. When you get repeated shoulder dislocations, or you have what's called a shallow capsule, or you have Ehlers-Danlos, some kind of Marfan's, you might have collagen that doesn't really seat and it's too flexible. So these people can have their shoulder pop out. To test this, you can stand above and kind of push down, pushing the humeral head forward. If the person guards and has apprehension, that's indicative that the anterior or inferior part of the capsule is used to being dislocated and she's scared it's going to happen again. You can also test the capsule by this kind of drawer test, as you would do with the knee, sliding the shoulder up and back, or ventrally and dorsally. When your shoulder has been dislocated so many times, they call it multi-directional instability or MDI. So it's just like not even used to being seated properly. You can elicit this by pulling down the hand, and you'll see this sulcus sign. The patient shows this giant gap between the figure of the femoral head and where it should be tightly, snugly attached. Again, shoulders dislocation shown above. So let's talk about the common injuries. Here are the bones. As we talked about, the shoulder blade forms one half of the glenohumeral joint. That's the glenoid. And then you remember the underneath the acromion, there's the subacromial area. So you got your one uh, internal rotator that's on the anterior side, the subscapularis. And so this is looking through the patient on the left, through the chest, and on the inside lining. without the spine is this internal rotator called the subscapularis. Uh, Flip around on the back, and you have three muscles: the supraspinatus, of course, above the spine posteriorly, infraspinatus, below the spine, and the teres minor, which are all external rotators on the posterior side. Just for completeness, we'll talk about neurogenic shoulder pain. Sometimes people's shoulders hurt. It's because this nerve plexus leaving the neck hurts. And you can elicit this with a Sperling test. Have the patient tilt their head, push down on it, and if it elicits the pain, that means you have a brachial plexus impingement or neurogenic shoulder pain. So, common injuries, rotator cuff injury one is the subscap. That's what I had, perhaps from wheeling luggage or doing my chaturangas. So, again, it inserts on the anterior humerus here, and it's lining the interior surface, the interior anterior surface. So, yeah, that's a common one, subscap. You can elicit it by having the person put their hand behind their back like they're being handcuffed. And when they lift off against resistance, if it hurts, you know what you're talking about. And I want to point out that, see, it doesn't really get that close. It'll trickle down from the subacromial, but arguably, if you're trying to heal a subscap, you might want to inject it more towards the insertion of the humerus, which is anatomically safe. On the backside, we have the infraspinatus and arguably the teres just below it, teres minor. And these are external rotators of the arm. Good way to test this is have the person flex their arm at 90 degrees at the waist and just have them push out. If it hurts, then that's your infraspinatus. And again, a subacromial injection will trickle down and do that. Sometimes you'll inject it also at the insertion at the greater tubercle of the humerus. Third one, very common, is the supraspinatus, and this is above the spine. And so this will clearly get treated by a subacromial injection. Again, this is an external rotator and an abductor. So you get the patient to do this, empty a can like that, and you push down. And if it hurts, well, then that is the supraspinatus, that is tendinotic. So, what are our treatment options? We have physical therapy and time. During that time, the body's inflammation and stem cells might produce enough exosomes to heal it. If you want to understand the difference between prolotherapy with PRP and steroids, I go into that more in Exosome Video 5, which is tiny URL ExoWeb 5. Of course, if you have just a acromial bone spur, the doc can go in and shave it off with these instruments shown in the middle. Just shave off the bone spur. That might provide easier passage of the tendons. And then the bulwark of what people have been doing is using ultrasound or just blind injections into the subacromial bursa. At this point, I just like a blind injection. I don't find the ultrasound adds much. There is a training course I took, which was very good. They teach you all these clinical signs and how to do it with the ultrasound. I don't feel it adds much. The final common pathway is the shoulder replacement. There is a total, which means that the glenoid cup and the humerus has a titanium ball in it. There's the hemi. You can do just one side or the other. And then you can do reverse, which means that the glenoid becomes a half sphere and the cap is a flat surface. This is generally what we're doing. We will mark out and we'll use a spinal needle. And depending on just the direction, it's the same entry point, and we will go for the subacromial bursa. So we do a clinical exam, we figure out where the problem is, we compare it with the MR, and then we mark the acromioclavicular joint. That is a very important landmark. Here it's shown the acromion and the clavicle kind of wrapping around. Really, what we want to draw out is the spine. And so you can see that above me in this cartoon, the spine, it looks kind of too broad and flat, but that gives you an idea. That's where the muscle of the supraspinatus is passing under. So to get to our subacromial injection, we use this long spinal needle and we go under the angle of the lateral part of the spine, about a finger breadth below and a finger breadth medial. If we want to inject the joint, instead of aiming for the subacromial bursa about 1 to 2 centimeters deep to the skin, We'll aim for the coracoid on the front of the chest. Coracoid can be found by having the person do a bicep curl. There's a bump there where that short head attaches. Mark that, mark the AC, mark your spine, and you got all the landmarks you need. So if we're going into the glenohumeral joint, you can see it's a little shorter distance. And instead of going up, we go sort of in plane towards that bump on the front of the chest, and we hit the head of the humerus every time. Of course, exosomes are not FDA approved for shoulder injury, but here are just some vignettes of cases. I would say that the response rate varies a lot by two things: age and the level of re-injury. So if we look at age, take a look at this study from the year 2014. They looked at a bunch of people from the young age group to the old. Even in the young, meaning less than 20, there's almost a 10% rate of injury to these rotator cuff tendons. But if you get into the octogenarians, it's 62%. So basically, with or without symptoms, it seems to be that as long as you get older, these things are like belts in your car. They're going to wear out, they're going to break, and there's nothing or not much you can do about it. How do people get injured? Well, people do maniacal golfing. They fall on skis or snowboards. They played rugby when they were young. They fall off of mountain bikes. So, yeah, there's that. One of the first patients I treated was BH, a 51-year-old airline pilot. He fell snowboarding and tore his rotator cuff. The first injection, it was only 50% better. I said, "I'm so sorry." He said, "Why be sorry? It's 50% better." He came back in a month and then he got to 100%, which taught me a lot. So, VS is an actor. At the time, he was 57. Again, he had the same pain in the front, subscapular pain. And he was quoted as saying, since treatment, he does his strength training without any pain. LL was an 81-year-old who came with his wife and they got treated. His right rotator was hurt and for years, and we did a subacromial injection. And he said, I don't know if it helped or worked, but it's completely healed. Now, AL was also one of my original patients. At the time, he was 54, very muscular guy. And so we did combine MSC and amnio exosomes for his left subacromial bursa. He emailed me, "Doc, I feel like I'm 18 again. There's no pain." And unfortunately, I didn't warn him not to act like he's 18 because he's bench pressing his personal max and he ended up tearing the other shoulder up. So that I, over the years and the iterations of the aftercare, I always warn people, baby it. Just because the pain goes away, that's actually a danger sign because you don't have the natural warning to take it easy. And it takes at least 2 months to regrow cartilage. A sadder case just this year was TM, a 91-year-old gentleman who had significant improvement. He said it was like 25% better in one shoulder and somewhat better in the other. He came back after 4 months for a retreatment because he really needed his shoulders to do activities around the house and care for his wife. 3 years of this pain seemed to get better, but unfortunately, the second treatment didn't really improve. And so this brings up an important point, a point that was illustrated to me yesterday by a question from a patient. He said, "What does this mean? These are the exosomes I got," and they sent me this chart. A lot of numbers here, but I just want to turn your attention to their newborn exosome product is on the left. The numbers are 4 digits, right? Big numbers. 21-year-old, half that. 37-year-old, a third. 61-year-old, maybe a fifth. What is the point? When you PRP somebody, their platelets have exosomes too, but they're less effective because old stuff just don't work as good. So your old stem cells don't work as good. So we have two things. We have the music that's being played. Is it jazzy? Does it have a lot of notes? And the listener, do they have the tendons, ligaments, the rhythm, the cognition to dance? So just like these dancers, maybe tween age versus octogenarian, you give young music to young folks, they do better. You give young music to old folks, they do better. You give old music to old folks, they don't do as good. Above us, we're reminded that aging and rust never sleeps. Our stem cells are always being depleted throughout our bodies. So, what we're giving you is newborn baby stem cell exosomes. But again, 91 years old with like completely shot rotator cuff tendons and osteoarthritis. You have to be tempered in your prognosis. As with the other procedures, subscribers to the course will be able to download these protocols. The protocol on my left, we won't go completely into. Also, in the future, when I get a chance, I'll upload a better video so you can see me doing these two procedures. What you can see there above is me having drawn out the spine. With the shoulder, there's a lot of variation in the anatomy, the location of the coracoid, the angle, and the height of the spine of the posterior scapula. So you have to always customize this, right? But the general gist of it is you have a 3.5-inch needle. You're either angling up to the supracoroidal bursa or you're angling kind of level to the glenohumeral joint. So, yeah, I guess the highlight is that you want to obviously mark your landmarks, the AC, the coracoid, the spine. You want to do a pen cap impression NX. You prep it, change your gloves, and then you're pretty much right at that angle where the spine turns. You're about a finger breadth in and a finger breadth inferior. Sometimes you'll hit the bone. That means you're too acutely vertical. And you want to either remove the needle all the way and lower it a couple of millimeters, and then just try again without such an acute upward angle. And yeah, there's no anatomy here. The lung is far away and on the other side, and you don't have the dangers that you would have. Mm. So here's a picture from 9 years ago, Paris Wax Museum. My son laying his head on Ernest Hemingway's very broad shoulders. And if you like this video, please like, subscribe, and share, and hit the notification bell. I have the book Exosome Songs of Healing. We have for Hay House, I wrote The Telomere Miracle and my original The Telomere Time Bombs discussing the stem cell theory of aging. And next week we'll talk about face and hair. And you can sign up for the provider training course at rechargebiomedical.com/courses. And therein you will have perpetual access to uploaded videos, these protocols, and a 12-hour training with 20 lessons on how to use exosomes.